Right, bit of light relief now, really. So we're going to talk about wrong side blocks, which is, I've always thought is a very binary thing, isn't it? It should be really simple to sort of get rid of. We should never really do them and all those sorts of arguments. But as we all know, that these things happen. First, I've got no declarations of interest. Thanks to Paul, a lot of these slides come from his presentation to the association last year, so thanks to him for lending those to me. So first of all, how common are wrong side blocks? Well, to put it in context, we think about how common is wrong side surgery. Does anyone have a figure for how common wrong side surgery is, roughly?
1 in 2.
So this is a figure from a large database in America. It's about 1 in 100,000 wrong side surgery. How common do you think wrong-sided blocks are, what we're doing? Higher or lower?
Higher.
So these are obviously very rough figures because they come from various size databases, but we're doing them quite commonly, actually. About 1 in 2,500 confidence limits allowing, maybe even 1 in 1,000. So it's really quite common. Next argument is, is it really an issue? Making a bit of someone go numb for a bit, on the wrong, is that really a problem? Should we really be worried about it? Well, I think probably we should be, because of a number of reasons, really. It can cause unnecessary complications. You can obviously damage a nerve that you're blocking. You can cause respiratory failure with an interscalene block. We all know there are lots of complications that you can cause with a regional block. It may mean that you can't provide adequate analgesia to a patient, particularly if you haven't recognised that you've done it. It can lead to cancellation of surgery, and it can obviously delay people leaving hospital. If you've numbed the wrong leg and then you numb the right leg, the patient obviously can't walk afterwards. They're going to have to stay in hospital. I think one of the other things that's really quite important is it really gives you as an anaesthetist a really bad experience. It's a really nasty thing to happen to you, and I say that as not something you've done, but to happen to you, because I think the important thing with all these types of instances is not to actually put blame on an individual for doing it. It's always a system problem, as we'll see in a minute. And of course, the one in capital letters there is it can, of course, progress to wrong side surgery, and that's why it's become a never event. Wrong-sided blocks have been implicated in a chain of events that have led to wrong-side surgery. The next thing is it has been made a never event since 2014, and there have been litigations, as I'll show you a couple of slides in a minute. So this is the never events list from 2018. The one at the top there is the surgical never events, and as you can see now, wrong site block has been included in wrong site surgery as a never event. So whether or not you think it's important, it's certainly been taken seriously by all the trusts and the powers that be around the country. This is a list of national safety requirements. You can see halfway down there now, stop before you block, which is one way of trying to stop yourself doing a wrong-sided block, has been included as a national safety requirement. So whether you think it's a good idea or not, and we'll see some slides in a second or two as to how successful stop before you block is in stopping you doing these things, it is expected that you now do it. There has been some litigation and some successful litigation around wrong-sided blocks, so there's another reason for trying to avoid doing one. This is a survey by the NHS Litigation Authority, 10-year period. 30 claims in that 10-year period related to blocks, to regional anaesthesia, and 10 of these were due to wrong-sided blocks. This was another data trawl in orthopaedic theatres over a 15-year period in England and Wales, and in this period there were 2 successful claims after wrong-sided block. This was a Canadian 7-year sort of data trawl of closed claims, and again, wrong side block cropped up once as a successful claim, of 19 claims due to regional anaesthesia. So what about us? So just take you back to 2009. Regional anaesthesia was undergoing this huge renaissance. We've got all these fantastic ultrasound machines appearing all over theatres. At the Queen's Medical Centre, we were doing lots more blocks in trauma, hand surgery. The Regional Anaesthesia Fellowship was in its, I think, 6th year by that point. And we were doing perhaps about 3,000 blocks per year across the two trusts. So in the year of 2009, we had 5 wrong-sided blocks, which, allowing for confidence limits and all those sort of things, is still probably quite a big number. And I was being asked to do quite a few of the investigations into them, which was, just seeing them crop up time after time. So we thought we were doing around 3,000 blocks per year. Now, just to put that into national context, 2010, Safe Anaesthesia Liaison Group did a survey of wrong-sided blocks before surgery. They felt the denominator throughout England and Wales was around 420,000 blocks, and nationally we were getting 67 reported wrong-sided blocks. It was just over a year period, about 15 months. So, whichever way you look at it, we had a rate of around 1 in 600 over that year, and nationally around 1 in 7,800. So you could say that we, in theory, placed about 10% of the wrong-sided blocks nationally, which was quite a number, really. And, of course, you can get blips and so on, but we thought that was really quite a big number. So what I want to do now is just take you through a case study of a wrong-sided block. And what I want to highlight or get you to think about is some of the things that can actually occur on a normal day on the job that might result in a wrong-sided block. So this is an experienced consultant regional anaesthetist. Case was a hand case, fasciectomy, palmar fasciectomy. The patient requested a GA. So the plan was for a laryngeal mask and a median nerve block, quite reasonable. The team briefing and the WHO signing was done correctly, and that is almost without exception the case in all of wrong-sided blocks that I've looked at. So then patient came to the anaesthetic room, and the first problem that occurred was the intravenous access was really difficult. So the anaesthetist then got the ultrasound machine out, tried to get a drip in. It was really difficult, didn't manage to do it, eventually got a 22 gauge in. And it was noted afterwards that the ultrasound machine was on the opposite side of the patient to where it would usually be to place the nerve block for that anaesthetist. The LMA didn't fit too well. It was a bit tricky, had to be fiddled with. They changed the LMA, changed the size. So that was a bit of an issue. And the anaesthetist left the ODP, taping the LMA in and bagging the patient whilst they were going to place the block. The anaesthetist then sat on a stool and put the block in, unfortunately, on the wrong side, but recognised it straight away and placed one on the correct side. So why would an experienced anaesthetist put a block in on the wrong side? Hands up who doesn't think this could happen to them. That's good start. Okay, so anybody, what sort of things were going on here?
It's because the machine was on.
Okay.
The machine dictated where he sat.
Great. So that's the first thing. The ergonomics weren't normal. Anything else?
Distracted by tricky airway and IV access, so you're already a bit tough.
Yeah, absolutely. Time pressure. Yeah. It was already a bit behind the curve. It'd all been a bit difficult. Fantastic. Yeah. Assistant was distracted, looking the other way. Yeah.
General anaesthesia, so the patient can tell you.
Absolutely. So not quite the normal perhaps technique, and actually having to do 2 techniques, general anaesthetic and a regional anaesthetic. Good. So the patient had requested 2 techniques. There's a time delay between the sign-in and the nerve block. I'm just going to raise that again because this is one of the things that SALG brought up in their review. IV access was difficult, rushing to make up time, mentally distracted by the tricky airway, and probably a bit worried because, they're kind of listening to LMA, is it still leaking, etc. Ultrasound machine on the unfamiliar side. We had, I think, 2 or even 3 wrong-sided blocks at City in about this time period, where the main thing the anaesthetist felt was the problem was that the power lead on the ultrasound machine was too short. So they had to put the machine on the wrong side of the patient to what they'd usually use, and they felt that was the biggest contributory factor to them putting it on the block on the wrong side. So it is an issue, the ergonomics. And of course the anaesthetist and the assistant concentrating on different jobs. So if we just sort of think about some of those things just sort of in list form, we can just go through it. So patient factors contributing to the wrong side of blocks. Patients who are sedated and confused, doing a block after a GA or a spinal can contribute. Difficult intravenous access, difficult anything, spinal, GA, anything that's going to distract you. Prone positioning of the patient's a classic. So position your patient prone for a popliteal fossa block, then you turn them on their back and you put a saphenous block in the wrong side because it's on the other side. That's a real classic. I've nearly done that a number of times. Multiple blocks on the same patient. If you're ever performing more than one block, let that ring alarm bells to you. The wrong site can be marked. The mark can be covered. So we had a wrong site surgery at the Queen's Medical Centre about 15 years ago, I think it was, where the ODP literally put the tourniquet on the wrong side and the mark was covered up and they just did the surgery on the wrong side. Marks can be transferred. So there's been lots of correspondence into anaesthesia of marks being placed on forearms and people folding their arms and transferring the mark onto the other side, and the same with crossing legs. So a number of surgeons have taken to actually writing the operation so it goes over in mirror image to the other side. Tourniquet placed on the wrong side. Similar patient names is another good one, just sort of getting the wrong patient. Factors affecting us, and some of these obviously overlap, but time pressure is a big one. Something's been difficult, the list's overrunning, you've got a surgeon who's jumping about trying to hurry you up, perhaps a senior surgeon with a junior anaesthetist, those sort of issues. Fatigue is a big one, and we're all guilty of it. We all come to work when we're feeling tired because we feel we should. That's another one. Just be aware of your own, if you like, foibles. If you're tired one day, then just take things a bit more slowly and check a bit more carefully. Poor communication is a massive one, and that's between everyone. That's all members of the team, you and your assistant, your ADP, you and the surgeon, you and the theatre team, all of these things. Lack of understanding of the theatre team. We had a wrong-sided block where the theatre team came into the anaesthetic room just as the anaesthetist was about to put block in. Can I borrow the ADP to move the patient off the table, please? Anaesthetist very, generously let the ADP go in and help. Was distracted, put the block in on the wrong side. That's another absolute classic. Change of personnel, tea breaks, lunch breaks, all that sort of stuff. You might lose your assistant. So all of these things result in that final, just a little bit of distraction, loss of concentration, just before you put the block in, and then you put it on the wrong side. Other things, unfamiliar, poor environment. Anyone who's doing blocks in Theatre 19 at the Queen's, there's just no room in there at all. You're squeezing between the bed and the wall and trying to get the machine up to the other side, and everything's really cramped. Anaesthetic room traffic. Don't let people walk through your anaesthetic room when you're doing an anaesthetic. Poor list order. So you're doing site surgery, shoulder list, for instance, and you're going from left to right to left to right. It's always a bad, organisational thing. Don't be a sole practitioner. Always have an assistant. Overbooked list, order change, all these things. Length of the anaesthetic machine cable. All of these things contribute. So it's really just, I suppose, having it in your mind as an anaesthetist responsible for putting a block in. Have all these things in your mind and just use them as little alarm bells to make you concentrate that little bit harder. So in 2011, we wrote this correspondence into anaesthesia around stop before you block. I don't actually know who actually thought of it. It might have been Paul who actually thought of the trendy name, but it certainly caught on. And one thing that SALG had said to these 67 national wrong-sided blocks was that they wanted everyone to check the mark on the patient at the time of signing. And certainly in all of our 5 wrong-sided blocks, we saw that the signing had been done correctly. So we felt that the real issue was the temporal delay from sort of checking what side you were going to do and actually performing the block, and it all involved various levels of distraction that we've already discussed. So what we wanted to do was institute a final check, if we could, immediately before needle insertion. So you do your sign-in, and immediately before needle insertion you visualise the arrow, you ask the patient if they're still awake, and you double-check the consent form and then put the block in, hopefully on the right side. So it was separate, and it was in addition to the WHO checklist, immediately before needle insertion. And we also said it should be a 2-person verbal check. So we wanted to try and involve the assistant, the ADP, or whoever was assisting, could be anybody in the anaesthetic room, to check with the anaesthetist that they were doing the block on the correct side. As you know, it's sort of all caught on. Stop Before You Block is now sort of on the college website. You can download the toolkit, as it were, to do it. It sort of went global. Ezra put it on their website, so it got translated into Polish. Australia and New Zealand sent us an email, said, can we use it? Of course you can. And wrong-sided blocks, I just took a screenshot from the Ezra Academy. It's still massive. People are really interested in wrong-sided blocks still, because they're still happening, unfortunately. And these are all individual abstracts that have appeared on the Academy around wrong-sided blocks. So there's a lot of people still interested in it and trying to stop it happening. So if Stop Before You Block is a useful thing to do we actually do it in Nottingham? Well, we sort of do, and it sort of comes and goes. These were just the last four audits we've done into how commonly it is performed. City are usually better than Queen's, but neither site is 100%. So for anything to work, 100% of the time, you've got to be doing it 100% of the time, and we clearly aren't. And there are probably a number of human factors related to why we don't do it. The next question is, does it actually work? I can't actually answer that question. I think in Nottingham, we've only had 3 wrong-sided blocks in the 7-year period from 10 to 17, so you could argue that it is helping, and I would argue that it is helping. But it certainly isn't a cure-all. And if you look nationally at these rates here, you can see that the rate of wrong-sided block isn't really changing that much, even after it was made a never event. NAP5 looked at the estimated incidence of wrong-sided blocks, and that incidence of 1 in 6,250 is about the national incidence that has been in there for the last 10 years. So it's not really changing very much. It's a little bit depressing, really. Do we actually do it here? So, this is another issue. This is Professor Moppet, I think at a college updates meeting was it? Little Twitter poll. So he asked, I think this is right in, you asked them, when do they do the stop before you block? When do they do the stop moment? And you can see that 60% of people did the stop moment just before needling, and the rest of them did it at various other points that really negate the actual process of doing it just before you put the needle in. So even people who are doing it, who admitted to doing it, are probably doing it correctly 60% of the time. So how do we sort of encourage people to check a bit more vigorously before they do a block? Well, you can do block site marking. So that one on the left there is my shoulder surgeon. He always puts a B for block for me on the correct side, well, hopefully the correct side. You can put a sticker on the wrong side. So if you go to the wrong side, there's a big no entry sign staring at you. There's a guy in Lancashire. You can make a big block box so you can't get anything out until you've checked and you're about to put the block in. Or you can do what we went for to try and remind ourselves and try and make ourselves do this stop moment. It's very easy to get distracted and just pick the needle up, stick it in the wrong side. If you put a sticker over your needle packet that's staring at you when you pick the needle up to put the block in, hopefully that reminds you to do the stop moment, the stop before you block moment. So, yeah, I personally use these all the time for every block that I do, and I think it's a really useful sort of way to remind yourself. and hopefully they're in all the anaesthetic rooms around the trust. Slightly extreme way of getting you to check. This is J.D. Pandit, who's one of the editors for Anaesthesia. He's a very cerebral guy, and he had to think about this, and he reckons what you should do is a mock block. So he picks up that syringe full of air, and he goes to the patient, stands over them and says, I'm placing my block. Am I doing it on the correct side? And they checks with the patient, checks with the assistant. And once he's done all that, he puts the air syringe down, picks the next syringe up and places his block. So this is in Oxford. So his rationale for this is that there's never been a report of 2 consecutive wrong-sided blocks in any patient. And he thinks this reduces your chance of doing it from 1 in 6,000 to 1 in 39 million. I think, just for that instance is just brilliant in itself. I don't think you can ever get a bunch of anaesthetists to do a mock block in every block they do. So, but there you go, that was J-Dip's take on it. One of the things we've been trying to do for a few years now is get industry involved, because obviously just about every block that's placed these days, an ultrasound machine is used, and the ultrasound machine, as you know, has been implicated in actually blocks being placed on the wrong side. And the idea is that, why can't we get ultrasound machines, when you turn them on, to come up with a screenshot saying, frozen, stop, don't do it yet, until you actively, just as you're about to put the block in, click it and start scanning and put your block in. So we've always felt that this would be a great idea, but it's very difficult to get industry, involved in doing this. Mindray are one of the few that have actually taken it on and been quite encouraging, and I think they are actually trying to do this. What they've done at the moment is they've allowed you to put a screensaver on the T7 machine so that this comes up as a screensaver. It's not quite there yet as a freeze as you turn the machine on, but I would hope that industry will take this on at some point in the nearish future, just to help us a bit more with wrong-sided blocks. So in summary, I think we've all got to accept that wrong-side blocks are inevitable. They're still occurring. They will still continue to occur. It's a human error. I think we should try and reduce their incidence. We need to all be aware of all those contributory factors that take place to make us put a block on the wrong side. I think the way to stop us doing it, or to help us stop doing it, is to try and remember to do a stop moment immediately prior to needle insertion, and always make this a 2-person check. Try and establish the culture in theatres that your assistant is involved with you in doing it. Consider a physical barrier like a sticker. I think it does help you remember to do it, get into the habit of using them. And I think the most important thing is to build a culture. I think I certainly grew up in a culture where this sort of checking wasn't that huge. The Who sign-in, there was no such thing when I started anaesthesia. So I think we are building a better safety culture. I think we are accepting that, we are getting better at it and we're more engaged in it. But I think we just must continue to be vigilant. We'll continue to audit stop before you block. The important thing, I think, is to teach our trainees who are the next generation of consultants to really carry forward this safety culture, and this is one example of that. Thanks very much.